The following podcast is part of a certified educational activity titled Timing Matters, Expert Insights on When to Use Targeted Biologic Therapy for Patients with Eosinophilic Esophagitis. Access the entire activity and complete the post-test at peerview.com/GXN860. Downloadable slides and practice aids are also available.
Hello, this is Dr. Nirmala Gonsalves, Professor of Medicine from Northwestern University, Feinberg School of Medicine. Welcome to this educational activity called Timing Matters, Expert Insights on When to Use Targeted Biologic Therapy for Patients with Eosinophilic Esophagitis. Our goals for today are to describe medical and dietary treatment approaches in controlling inflammation in EOE and limitations that may exist with treatment. To discuss the rationale for the use of targeted biologic therapy in the treatment of EOE based on the role of type 2 inflammation and recent clinical evidence, and to understand how to integrate targeted biologic therapy into treatment plans for patients with EOE in a timely manner to optimize outcomes. So let's take a closer look at the standard of care in EOE. When we think about treating EOE, we talk about treating to target. So what does that mean? We want to target different endpoints. The first is symptom activity. We want resolution of dysphagia without the need to avoid food based on texture. We definitely want improvement in histologic activity, ideally resolution of esophageal eosinophilic inflammation or under 15 eosinophils per high-power field. We want improvement in endoscopic activity, particularly improvement in inflammatory features and stricture diameter, trying to get that stricture diameter over 15. If we can target all three of these endpoints, that's when patients have a complete response. I'll walk you through a suggested approach to managing EOE in this algorithm. So in patients who have esophageal eosinophilia, they have over 15 eosinophils per high-powered field, you've already ruled out other diagnoses such as GERD, achalasia, lichen planus, caustic or infectious esophagitis, non-EOE agents, and inflammatory bowel disease, and you've clinically made the diagnosis of eosinophilic esophagitis. It's important to start a shared decision-making approach with your patients and discussing various treatment options with them. The decision on which treatment really depends on patient-specific goals and patient motivation. So some of the various treatment options you may approach with your patients are PPI therapy, which is favored as an initial approach due to cost and safety profile. PPI therapy is typically twice daily. However, only 30 to 50% of patients are PPI responsive. Other therapies seen in this algorithm that can be used include food elimination diet, given the cost and safety profile, and favoring an empiric elimination diet, swallowed topical corticosteroids, either with fluticasone or budesonide, or dupilumab, 300 milligrams sub-Q per week. And we'll discuss this further as the program progresses. When we talk about this treatment algorithm further, we want to think about optimization of therapy. Remember, our goals of treatment include symptomatic, endoscopic, and histologic remission. Oftentimes, monotherapy is used, and if that doesn't work, this is followed by combination therapy or escalation of therapy if not successful, based on that symptomatic, endoscopic, and histologic response. Certainly, if you have patients with strictures, dilation of this fibrostenotic narrowing is important. When we think about maintenance therapy, we want to continue treatment regimen that attained remission initially. And once patients are in remission, it would be important to repeat that upper endoscopy in approximately a year to confirm sustained remission, and then potentially every 2 to 3 years or with changes in symptoms or changes in therapy. Let's look a little bit more closely at treatment with proton pump inhibitors. Now, historically, back in the 1990s, PPI therapy was used for GERD with eosinophilia. In the 2000s, PPI response as a diagnostic criteria came about, differentiating a condition called PPI responsive esophageal eosinophilia versus EOE. And in 2018, the AGREE guidelines came out suggesting PPI therapy for EOE. So let's look at the AGA and Joint Task Force guidelines. They suggest that PPIs should be used over no treatment, and this is a conditional recommendation. Pooled studies show a histologic response rate of 42%. It works via various mechanisms, including anti-secretory and anti-inflammatory mechanisms. It's used as a primary therapeutic option, secondary to long-standing safety profile, ease of administration, and low cost. While there's some data that suggests twice-daily dosing might be more effective, that sometimes has issues with adherence. So once-a-day dosing is appropriate. So next, let's look at dietary therapy and the AGA and Joint Task Force guidelines on dietary therapy. They looked at elemental diet, empiric elimination diets, as well as allergy-tested directed diets, and favor the use of empiric elimination diets. They suggest using an empiric 6-food elimination diet over no treatment. This was conditional recommendation with low-quality evidence, and the percent achieving histologic response was 68%. Now, since the guidelines came out, there have been several different types of elimination diets. So what do you eliminate in an elimination diet? So when we talk about a 6-food elimination diet, that takes out milk, wheat, egg, soy, peanut, tree nuts, fish, and seafood. A 4-food elimination diet takes out milk, wheat, egg, and soy. A 2-food diet, typically milk and wheat. And a single food has been typically milk only. When we think about approaching dietary therapy for EOE, there are different approaches that one can do. The first is a step-up elimination diet versus a step-down 6-food elimination diet, and I'll walk you through each of these. So the step-up elimination diet, which has been described, initially has patients eliminate just 2 foods for 6 weeks, and those 2 foods typically are milk and wheat. They will eliminate these 2 foods for 6 weeks, and if their follow-up endoscopy has more than 15 eosinophils per high-powered field, meaning they haven't met remission, they're going to move on to a 4-food elimination diet for an additional 6 weeks, eliminating milk, wheat, soy, and egg. A follow-up endoscopy will be done at that time, and if they still have inflammation of over 15 eosinophils per high-powered field, they will step up to this traditional 6-food elimination diet for an additional 6 weeks, eliminating the milk, wheat, soy, egg, nuts, and seafood. The step-up elimination diet may lead to early identification of food triggers and shorten diagnostic process, but some patients may have to progress through the entire process. Now, this is slightly different than the traditional step-down 6-food elimination diet, where patients upfront eliminate milk, wheat, soy, egg, nuts, and seafood for 6 weeks. If they are in histologic remission, their eosinophils are under 15 eosinophils per high-powered field, they will begin a sequential reintroduction, ideally with the least likely culprits first, moving on to the most likely culprits. So, for instance, seafood first, and then nuts. Each food is reintroduced for 2 to 4 weeks, followed by an endoscopy after either 1 or 2 foods. So the traditional reintroduction approach is seafood, followed by nuts, then egg or soy, then lastly, milk or wheat, as they tend to have the highest risk. Sometimes multiple endoscopies, sometimes up to 7, with single food reintroduction, might be needed, and this process can take upwards to 42 weeks for the full reintroduction. What about data for swallowed topical corticosteroids? Well, the AGA and Joint Task Force guidelines suggest swallowed topical corticosteroids should be used over new treatment, and this is a strong recommendation. And based on the AGA and Joint Task Force guidelines, pool studies suggest achieving histologic response in 65%. The treatment provides topical coating to the esophagus. It's safer and similar efficacy to systemic corticosteroids. Adverse effects such as esophageal candida infection, decreased bone density, adrenal insufficiency, and decreased linear growth are uncommon. So when we piece all these approaches together, there are advantages and disadvantages to conventional approaches. Remember, again, we're approaching this in a shared decision-making manner together with our patients. So it's really important to think about what their goals of therapy are. For instance, swallow topical corticosteroids have a very high efficacy, and there is a strong recommendation with moderate certainty evidence. Adverse effects have been noted as described in the prior slide. There's no need for periodic monitoring with endoscopy. In terms of monitoring, there is a need for follow-up endoscopy to monitor response, and this is true of any treatment. Lifestyle changes, it should be taken daily or twice daily, depending on the dose that achieves remission in these patients, and the price can vary on the basis of coverage. When it comes to PPI therapy, data suggests that it works for less than 50% of patients in most series. This is a conditional recommendation with very low quality of evidence. While previously there were concerns for renal and other adverse effects, this has not been confirmed in a large randomized controlled trial, although there may be a slight increased risk of enteric infections with prolonged use. Similar to other therapies, there is a need for periodic endoscopy to monitor response. It should be taken daily or twice daily, depending on the dose needed for remission in your patient. And there is over-the-counter availability for many of these agents and generally less expensive than some of the other options. When we think about dietary therapy, the efficacy is considered high, highest for elemental diet versus empirical elimination diet, but elemental diet has its challenges, which is why the guidelines suggest using an empirical elimination diet. Adverse effects could be nutritional deficiencies, anxiety or poor quality of life in patients, and prolonged diet restriction can lead to patient frustration. Monitoring is necessary to assess efficacy and histologic remission. It's important also to monitor for overall nutritional and growth status with any dietary elimination. In terms of lifestyle, there is potential to affect the patient family at meals, and it can be disruptive to some families. So you need to think about quality of life in this approach. In terms of costs, it can be expensive to buy replacement foods or special formula. So when we talk to patients about various therapies, it's important to review all the pros and cons with them and make a joint decision prior to moving forward in treatment. So let's review the case for targeted therapy in EOE. And what does the latest evidence say? So when we look at the pathophysiology of EOE in a broad overview, this affects mainly white patients in terms of heritability. There's a high relative risk among family members. There are genetic variants, such as GWAS or candidate gene studies have shown. In terms of gender, it mainly affects males in a 3-to-1 ratio. There's a higher family association amongst males. In terms of environments, twin studies and genetic studies have shown the importance of environmental exposures, primarily C-section births, antibiotics, formula feeding, and early NICU admission can increase the susceptibility to getting EOE. EOE has been associated with atopic conditions. There is evidence of seasonal variation, oral immunotherapy-induced esophageal eosinophilia, and there's a high rate of food allergy, atopic dermatitis, and asthma in our patients. Certainly when we think about cellular pathology, this involves activated eosinophils, mast cells, and impaired epithelial barrier. When we dive a little further into the EOE pathophysiology, this is a Th2-mediated condition recognized by infiltration of eosinophils into the esophagus, with activated Th2 lymphocytes increasing tissue levels of Th2 cytokines, and it results in chronic esophageal inflammation and dysfunction. When we look a little further into this schematic, we see that in a genetically susceptible individual with exposure to food or air allergens, this sets off an inflammatory cascade signaling IL-33, TSLP, and stimulating Th2 cells. This ultimately will start secreting pro-inflammatory cytokines such as IL-4, IL-13, and IL-5, which ultimately lead to eosinophils and mast cells trafficking to that esophagus, causing eosinophilic inflammation, loss of barrier, and remodeling, and this results in chronic esophageal inflammation and dysfunction that we see in our patients. We think about EOE as being an atopic condition. This slide nicely demonstrates the frequency of atopic comorbidities in patients with EOE. For instance, allergic rhinitis can be seen in 59 to 61% of patients, asthma 35 to 49%, atopic dermatitis 28 to 61%, and food allergies in 54 to 76%, depending on what population you're looking at, whether it's adults, adolescents, or young children. In these patients, it's common to have more than one atopic disease. 78% reported at least one atopic condition, 48% reported having more than one, and 22% reported having at least three: allergic rhinitis, asthma, and atopic dermatitis. Now, what's interesting is that the history of food allergy or atopic dermatitis is associated with a significantly shorter time between symptom onset and diagnosis. So it's important to assess for EOE when patients present with symptoms of esophageal dysfunction, in addition to any of these atopic comorbidities. So the question comes up, why biologic therapy for EOE? Corticosteroid refractory patients or corticosteroid intolerance is one scenario. The concept of targeting therapy specific allergic pathways, systemic treatment of multiple forms of atopy, and the practical benefits of weekly rather than daily therapy. So let's look a little bit closer at some of the biologic therapies. For instance, dupilumab, which is an anti-IL-4 receptor alpha compound. This inhibits signaling of both IL-4 and IL-13. It was approved in the U.S. for the treatment of moderate to severe atopic dermatitis in patients over 6 months, moderate to severe asthma in patients over 6 years, chronic rhinosinusitis with nasal polyposis and prurigo nodularis in patients over 18, and in May of 2022, approved for EOE in patients over the age of 12, and recently approved for pediatric patients over the age of 1. Let's look at the data that led to that FDA approval. Dupilumab reduces dysphagia symptoms, maintains histologic remission at 24 and 52 weeks, and this was seen in the Liberty EOE Treat study. This was a weekly subcutaneous dupilumab. In this study, weekly subcutaneous dupilumab was associated with improvements in both histology and symptoms among adults and adolescents with EOE. 60% of those treated with dupilumab achieved a histologic remission versus only 6.3% in the placebo group. Patients treated with dupilumab also experienced reduced dysphagia symptoms, a 10-point greater improvement on the mean DSQ score versus placebo. Common adverse events occurring in over 10% of patients in any dupilumab arm included injection site reactions, erythema, pain and swelling, and nasopharyngitis. Dupilumab improves histologic and endoscopic features of EOE, as well as the rate of weight gain in children ages 1 to 11 years in the Phase 3 KIDS trial up to week 52. Here we see their data, looking at the proportion of patients with peak eosinophil counts of less than 6 that occurred in 67.6% of patients on the dupilumab higher exposure dose at week 16 and 62.9% in dupilumab higher dose at week 52. There was also an absolute change from baseline in EOE HSS grade score and stage score. The proportion of days with over one EOE sign dropped significantly in the higher exposure dupilumab group, and the change in body weight for age percentage went up 3.09 up to 5.96 in the dupilumab treatment group. Overall adverse events were 79% in the dupilumab group versus 91% in placebo. Adverse events leading to study drug discontinuation were 0% in the dupilumab group and 6% in placebo. Moving now into another agent called cendakimab. This is RPC 4046, which is an anti-IL-13 compound. This is a recombinant humanized monoclonal IgG1 kappa antibody, highly selective for IL-13. It inhibits binding of IL-13 to the IL-13 receptor alpha 1 and IL-13 receptor alpha 2 receptors. It was administered as a weekly subcutaneous injection. Here's the data from a randomized double-blind placebo-controlled trial in 99 patients ages 18 to 65 years. This was a 16-week treatment. Patients received RPC 4046, 180 milligrams or 360 milligrams sub-Q versus placebo. The primary endpoint was a change in mean esophageal eosinophil count. The phase 3 study is ongoing. It's currently not FDA approved for EOE. Here's the data from the phase 2 study. On the left, you can see significant reduction in the low dose and high dose RPC 4046 patients compared to placebo. And on the right, you can see a reduction in the mean EREF score in both the low dose and high dose RPC 4046 groups compared to placebo. Other emerging targeted agents for EOE include tezepelumab in adults and adolescent patients. This is an anti-TSLP compound completing a phase 3 crossing trial. Barzolvolimab or CDS-0159 in adults. This is an anti-KIT agent doing a phase 2 EVOLVE trial. So when should targeted therapy be implemented in the treatment of patients with EOE? So going back to our suggested approach for this algorithm, if we look down at the bottom, you could consider using it as initial approaches in selective patients or patients who have severe disease or have been on concomitant treatments. So let's think about the criteria for the consideration of dupilumab for EOE treatment. Now, considerations for first-line use include multiple comorbid atopic conditions such as asthma, atopic dermatitis, or chronic rhinosinusitis with nasal polyps, or a strong preference to avoid dietary restriction or swallow topical corticosteroids. Considerations for use as step-up therapy include difficult-to-treat EOE, failure to thrive, poor growth, or significant weight loss due to EOE, frequent use of rescue therapies, severe dietary restrictions or requirement for an amino acid-based formula, clinically significant esophageal strictures or narrow caliber esophagus, refractory to current therapies, or adverse events from current therapies. When we think about monitoring biologic therapy, all patients with EOE need to be monitored after changes in therapy. Although symptoms can improve as soon as 4 weeks after starting therapy with dupilumab, to measure a true efficacy, a repeat EGD, along with obtaining biopsies, is recommended 5 to 6 months after starting dupilumab or whenever adjusting the dose. Repeat EGDs can be done earlier at a physician's discretion, depending on the circumstances. For instance, if you have a patient with significant stricturing and you need to repeat that dilation earlier, or patients with worsening symptoms. So in the case that you just heard about with the boy who failed PPIs, this scenario is really falling into consideration for the use as step-up therapy. So if you have a patient who has tried other medical or dietary therapies and is still symptomatic or having histologic inflammation, that is a perfect scenario to step up to the use of biologic therapy with dupilumab. So in the case that you just heard about with a 40-year-old woman with a multiple comorbid atopic conditions, this is a perfect example of someone you may consider using dupilumab as first-line use. Someone who does not want to add further topical corticosteroids to their existing regimen and who may not want to proceed with dietary therapy. So what's important to recognize when you think about positioning medications like dupilumab in your armamentarium is really talking to your patient, working through a shared decision-making approach, and coming up with that right strategy based on their severity of the disease, things that they've tried, and their own personal goals for treatments that they want to pursue. There's not a one-size-fits-all when it comes to treating EOE. So when you're using biologic therapy, you need to be monitored after changes in therapy, after starting therapy with dupilumab. To measure true efficacy, a repeat EGD, along with obtaining biopsies, is recommended 5 to 6 months after starting dupilumab or whenever adjusting the dose. Repeat EGDs can be done earlier at a physician's discretion depending on the circumstances. For instance, if you have a patient with severe stricturing disease and you need to proceed with serial dilations, you can repeat that endoscopy earlier for serial dilations. Or if you have a patient who's having worsening or escalating symptoms, that would be a time to do an endoscopy prior to that 5 to 6 months. Thank you so much for joining us, and I hope you found this program to be useful as you continue to care for patients with EOE in an evolving treatment landscape.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/GXN860. This activity is supported by an independent medical education grant from Regeneron Pharmaceuticals Incorporated and Sanofi.